ladies and gentlemen, it's a great pleasure for me to talk about the resolution of inflammation, which we consider as an important way out for many common inflammatory disorders. And we are focusing actually on lipid mediators, which impact almost all stages of inflammation, from the onset, the maintenance, and the resolution of inflammation. So in fact, unresolved low-grade inflammation is a major cause for many common diseases like cardiovascular disease, diseases related to bone and joints like osteoarthritis, osteoporosis, gout, chronic inflammatory metabolic disorders like diabetes, pancreatitis, Crohn's disease, colitis, sepsis, also Alzheimer's, Parkinson, then respiratory diseases including asthma, COPD, autoimmune diseases, of course, rheumatoid arthritis, multiple sclerosis, and finally even cancer. And many of those diseases are clearly related and increased with age. And there is a phenomenon called inflammaging, which is considered as a chronic sterile low-grade inflammation that occurs during aging. And this leads to age-associated diseases that I just mentioned and that you can see here. And actually, it's not entirely clear what causes inflammaging, but probably pathogens, endogenous cell debris, dysregulated molecules and nutrients, as well as the microbiome are apparently key factors. And what is also evident is that there is a disbalance of lipid mediators, shifting from pro-resolving towards pro-inflammatory mediators. And these lipid mediators are well known to regulate inflammation, as I mentioned before. And what you can see here is the time course of inflammation starting with a tissue damage by microbial infection, toxins, or trauma, which gives a rapid edema and a rapid influx of polymorphonuclear neutrophils and monocytes. And those cells mount the acute inflammatory response. Leukotrienes and prostaglandins are produced, which are pro-inflammatory mediators that increase the vascular permeability, cytokine production, phagocyte chemotaxis, and the formation of reactive oxygen species. And if those molecules here prevail, then chronic inflammation occurs, leading eventually to organ dysfunction. However, usually acute inflammation is also terminated. It's going to be resolved and tissue is repaired and regenerated. And interestingly, also here, lipid mediators play a key role, which are called specialized pro-resolving mediators that include lipoxins, resolvins, moresins, protectins. And these molecules are quite similar in structure as leukotrienes and prostaglandins, but they have opposite functions. They block neutrophil influx and activation. They promote the efferocytosis of debris, enhance bacterial killing, promote phagocytosis by macrophages. So clearly the leukotrienes and prostaglandins are detrimental molecules, whereas those are beneficial and make us healthy, so to say. So here we have an overview about the biosynthetic principle of lipid mediators, which is quite easy. Phospholipids are cleaved by a phospholipase A2 to release the polyunsaturated fatty acid, which is then a substrate for lipoxygenases and cyclooxygenases to produce a monooxygenated fatty acid, which you can see here. And these are then substrates again for lipoxygenases or epoxide hydrolases. And this leads to di- or trihydroxylated fatty acids, and these are the bioactive lipid mediators. Alternatively, these epoxides can be conjugated with glutathione to produce the cysteine leukotrienes and cysteine SPMs. Well, arachidonic acid is mainly converted to prostaglandins and leukotrienes, which are clearly pro-inflammatory mediators. They have specific G protein-coupled receptors, mediate pain, fever, inflammatory reactions, leukocyte chemotaxis, migration, vascular permeability, degranulation, oxygen radical formation. However, arachidonic acid also can be converted to lipoxins, and similarly, also icosapentaenoic acid and docosahexaenoic acid can be converted to resolvins, moresins, protectins. Again, these molecules are very similar in structure, like leukotrienes, prostaglandins, but have completely different receptors, high affinity receptors, and via these receptors, those SPMs cause resolution of inflammation. They cause sequestration of pro-inflammatory cytokines, inhibit neutrophil infiltration, increase phagocytosis of microbes and apoptotic neutrophils. They are organ protective, promote wound healing, tissue regeneration, and eventually reduce pain. So clearly, these beneficial effects are of interest in order to treat these unresolved inflammatory diseases. And in fact, there have been numerous studies only within the last few years in animal models addressing infection, acute lung injury, skin burned wounds, colitis, arthritis, periodontitis, Alzheimer, neuroinflammation, dermatitis, multiple sclerosis, cancer, atherosclerosis, depression, Parkinson, and so on and so on. And here these mediators have been successfully applied in these systems. So what are the major therapeutic strategies related to SPMs? Of course, clearly SPM application is reasonable. However, SPMs are not easy to get and hard to store. They're unstable. Another opportunity is to supplement omega-3 PUFA substrates and the monohydroxylated precursors. And finally, and this is what we are aiming for, to have drugs that in a smart way manipulate the biosynthesis of lipid mediators to promote endogenous SPM formation. So this is what we have at the moment on the market. These are nutritional supplements containing omega-3 fatty acids and monohydroxylated precursors. And those drugs or nutritional supplements are supposed to increase the biosynthesis of SPMs. And speaking about the biosynthesis of SPMs, I would like to introduce you the lipid mediator pathway in more detail, where arachidonic acid is liberated by phospholipase A2, and this is then converted by the cyclooxygenase to prostaglandins, and also can be converted by the 5-lipoxygenase pathway to leukotrienes. And as I mentioned before, these are pro-inflammatory mediators produced by neutrophils, monocytes, and M1 macrophages. However, those phospholipases also release omega-3 fatty acids like EPA and DHA, and also those can be converted by 5-LOX, as well as by an important enzyme, the 15-lipoxygenase. And they together make then the lipoxins as well as resolvins and protectins. And there is another lipoxygenase, the 12-lipoxygenase, that makes marasins. Again, those molecules, they have anti-inflammatory pro-resolving properties. And from a pharmacological point of view, it is reasonable to, of course, downregulate the biosynthesis of prostaglandins, leukotrienes, but elevate these SPMs. One possible way to elevate SPMs is, of course, supplementation of those omega-3 fatty acids. And this has actually been intensively investigated in animal models as well as in human trials with healthy individuals, but also with patients, and large amounts of omega-3 fatty acids were applied over weeks. And the outcome is not very clear. So here we have a recent review article by Phil Calder, who is an eminent scientist in omega-3 fatty acid, and I want to cite his opinion here. Human studies report that plasma or serum concentration of some SPM can be increased by increasing intake of EPA and DHA. However, the relationship of specific intakes of EPA and DHA to enhancement in the appearance of specific SPMs is not clear and needs a more thorough investigation. So therefore, we believe that possibly drugs that influence the lipid mediator pathway may be here very useful. What you can see here is Sune Bergström, Bengt Samuelson, John Wayne, that received the Nobel Prize 40 years ago for the discovery of prostaglandins leukotrienes. So these are clinically validated pro-inflammatory lipid mediators with, however, also several homeostatic functions. Knockout mice for enzymes and receptors of those molecules are available, and even more important, drugs are on the market that interfere with the biosynthesis of prostaglandins, which are NSAIDs. These are COX inhibitors like aspirin, ibuprofen, diclofenac, celecoxib. And these compounds also, however, block beneficial prostaglandin formation, and they promote leukotriene formation by substrate shunting. And this causes frequent and severe side effects that we all know in the stomach, in the kidney, cardiovascular system. And they also may counteract resolution of inflammation. So these prostaglandins here, we have in particular prostaglandin E2 at large amounts that is pro-inflammatory, while the other prostaglandins have many homeostatic functions. So that means by applying NSAIDs here as COX inhibitors, we block also those functions and we shunt arachidonic acid to the leukotriene pathway. So these are not ideal drugs, of course, but what alternatives do we have here? Well, if we look at this scheme again, then we have to know that 20 years ago an enzyme was discovered, which is the microsomal prostaglandin E2 synthase 1 here, which is a selective enzyme producing massive amounts of pro-inflammatory PGE2. So now from a pharmacological point of view, it's reasonable to have dual inhibitors that block this enzyme and the 5-LOX in order to suppress all the pro-inflammatory mediators, but not the homeostatic beneficial ones. And we have actually screened for such dual inhibitors, and keeping in mind the pharmacological relevance of those compounds to have high affinity, true targets here, a potency at concentrations that are achievable in the plasma, and proof of concept in vivo. And in fact, we found a couple of network products like curcumine, EGCG, hyperforin, gasinol, also carnosic acid, that dually inhibit these enzymes at even rather low concentrations in the nanomolar range here. So the question is, of course, do these dual inhibitors that block PGE2 by inhibiting MPGS1 and leukotrienes by inhibiting 5-LOX also elevate these SPMs? Well, in order to study this, we had to have a cellular system where we can detect SPM formation, and this is only 5 years ago, and it was not possible to have it right away. And we established such an assay by studying monocytes that were differentiated towards macrophages, and these macrophages were then polarized to pro-inflammatory M1 and anti-inflammatory M2 macrophages, and we wanted to stimulate these macrophages to measure lipid-mediated formation. But what stimulus should we use? We tried many stimuli, and we eventually found that pathogenic bacteria like E. coli in fact stimulate the M1 macrophages to make prostaglandins and leukotrienes, and the anti-inflammatory M2 to make lipoxins, resolvins, protectants, marasins. So you can see clearly different lipid mediator signatures of M1 and M2. And by using these macrophages, we wanted to find such a miracle drug that downregulates prostaglandin leukotriene formation but elevates SPMs. In this screenshot, we can see the report about a miracle pain reliever, and this is frankincense. And this turned out to be highly effective in a clinical trial with osteoarthritis patients that reported reduction in pain and increase in mobility in a few days. So frankincense is the gum resin from Boswellia trees, and it's well known as one of the gifts of the holy kings for Jesus Christ's birth besides myrrh and gold. And frankincense contains boswellic acids, in particular acetyl-ketoboswellic acid, AKBA, and this is a highly pharmacologically active compound. And it was found already 30 years ago that AKBA directly inhibits 5-lipoxygenase, and we found a couple of years later that it also inhibits MPGS1. So this is a dual inhibitor of MPGS1 and 5-LO. And by any chance, we observed in 2004 and 6 that AKBA activates 15-LOX and 12-LOX. However, at that time, those SPMs have not been known yet. So now we readdressed ACPA as activator of these enzymes. So first we looked at the 5-lipoxygenase again, and this is the crystal structure, the first crystal structure with an inhibitor, and this is ACPA. But ACPA bound far away from the active site of 5-lipoxygenase, and we were wondering whether this could affect the activity of the enzyme. Here again, you see ACPA, and to make a long story short, what happens here is that ACPA breaks the interaction between a tryptophan and an arginine here in this area, okay? And by breaking this interaction, it causes a domino effect towards the active site. And then we have a complete different conformation of the active site. And this looked like to have a shift from a 5-LOX to a 12-15 LOX. So ACPA shifts the reduced selectivity of this enzyme. So that means 5-LOX that usually incorporates oxygen at the 5 position here to give 5-HT and leukotrienes. In the presence of ACPA would incorporate oxygen at this position at 12 and 15. And we tested that by transfecting hex cells that have any lipoxygenase, no LOX, with 5-LOX and FLAP. And then you can clearly see that AKBA in blue blocks formation of the 5-hydroxylated products, those, but elevates in fact 12-HT formation and also 15-HT, whereas another direct active site inhibitor does not do the same. From this artificial model, we then moved on to neutrophils and M2 macrophages, incubated them with ACPA, and tried to see whether also in those cells ACPA would shift from 5-LOX to the 12-15 LOX. And in fact, what we find is that in neutrophils, 5-lipoxygenase activity is strikingly downregulated, but at the same time, as well as in M2 macrophages, 12 and 15 LOX are increased, as well as SPMs. Then analyzed extracts of frankincense that are available on the market and contain AKBA, and added those extracts to M2 macrophages to see whether they also could, like ACPA, increase SPM formation. As you can see clearly, they strongly increase the formation of resolvins as well as marasins protectants, even better than ACPA does at low concentrations. We then combined these extracts with a product containing omega-3 fatty acids, EPA and DHA. And interestingly, as you can see here, addition of this Unveiling here does not change any activity. No SPMs are formed. But when we add AKBA or these extracts, resolvin D5 is produced and even more in the presence of this EPA and DHA. And the same was found also for marasins, as you can clearly see here, and also for protectants. So combining Unveiling or EPH DHA with an activator of 15 LOX, that can actually induce SPM formation. We then also screened or we investigated other prominent anti-inflammatory natural products that are quite commonly used, like carnosol, carnosic acid, EGCG, resveratrol, habagosid from devil's claw, curcumin, patenolide, and so on, and checked whether they are able to induce SPM formation. So we used the screening where we have M2 macrophage, which is activated, and this activation usually causes an elevation of calcium, which is important for the phospholipase and the LOX to translocate to the nuclear membrane. Here then, the phospholipase releases the PUFA, which is taken up by the LOX to make the lipid mediators. And here we used again the M2 macrophages that are able to produce these SPMs. And we incubated those M2 macrophages with the natural products, studied cell viability, calcium mobilization, LOX translocation here, and of course the formation of lipid mediators. And here are the results. Again, here we have the compounds, we have the effective concentrations, and you can see that none of them reduced cell viability significantly. Some of them really induced the LOX translocation to the membrane. Some also increased the intracellular calcium, and among all of them, one compound was highly effective to induce SPM formation, and this was scilastrol. And this scilastrol, as you can see, is structurally quite related to ACPA. It's a pentacyclic triterpene with a carboxylic moiety here. It's contained in Tripterigium wilfordii, a plant from Asia, thunder god vine. Extracts of the roots are used in traditional Chinese medicine as an anti-rheumatic drug, also in Europe meanwhile. It is anti-inflammatory in many animal models. And again, what you can see here is ACPA from frankincense in 5 LOX, far away from the active site. And this position, this cleft here, can also be filled with scilastrol. So scilastrol should have the same effect as ACPA. And indeed, when we incubate neutrophils with scilastrol and stimulate with E. coli, we can see that The 5-lipoxygenase products are downregulated, all of them, in green by scilastrol, whereas 12-HED and 15-HED are increased. And in fact, this scilastrol is a potent inhibitor of the isolated 5-LOX, so a direct inhibitor of 5-LOX. We added scilastrol to M2 macrophages, and to make a long story short, what we find is a strong activation of the SPM precursors as well as resolving, and we see at the same time a downregulation of 5-LOX products. We then moved on to an animal experiment where we applied scilastrol at 10 milligram per kilogram IP to mice. We stimulated the mice by thymosin injection, and after 2 hours we measured cell infiltration and lipid mediation. Neutrophil influx was reduced by scilastrol, and importantly, what we find is that the pro-inflammatory 5-LO products and prostaglandins are downregulated by scilastrol, whereas the SPM precursors and the SPMs are significantly increased in vivo. Here we can see this in bar charts. 5-LO products downregulated, 12-15-LOX products increased, scilastrol in green, and this is translated into higher protect information, Werz information, and resolve information. What are our future directions we want to go? It's clear that many natural products and remedies have anti-inflammatory properties and promote inflammation resolution. And potentially this is done by a favorable manipulation of the lipid metabolic network. And in fact, we screened numerous natural products, and we found by any chance that those 2 chalcones from Melodorum fruticosum, a plant from Asia, when given these compounds to innate immune cells, we find exactly what we want to see. That is an elevated formation of SPMs, but a downregulation of the leukotrienes. And similarly, we found a novel compound, which we named compound 2. And this is derived from Cambodian dragon tree. And we screened actually 94 Vietnamese plant extracts, and among those, this came out, and we identified that compound as a compound that inhibits 5-LOX, that represses leukotriene formation but elevates SPM formation. What about oral enzyme combinations that are also used to treat inflammation, swelling, and pain, like wobenzym? Well, this is a combination of bromelain and trypsin, which are cysteine protease from pineapple and a serine protease from porcine pancreas juice. There is also rutocid contained, a flavonoid, and looking at the structure, it's quite similar to the 2 compounds I just presented in the previous slide. And this combination was shown to be highly active in osteoarthritis of the knee versus diclofenac, as good as diclofenac. And the mode of action of this combination is to proteolytically activate alpha-2 macroglobulin. So what is this protein? This is an acute phase protein produced mainly by macrophages. It is abundant in blood and also present in synovial fluid, and it's higher in osteoarthritis than in healthy joints. And it was shown that injection of this protein attenuates post-traumatic osteoarthritis progression, and recently it was shown when put into microparticles, it also enhances pro-resolving responses and promotes the survival in sepsis. And along these lines, there were also an increase of SPMs observed. So we wonder whether oral enzyme combinations like wobenzym may also promote resolution, and this could be via elevation of SPMs levels, which remains to be investigated. So I would like to thank my collaboration partners, Marcia Newcomer from Louisiana State University, Tonya Rossi from Naples, Charlie Sirhan from Harvard Medical School in Boston, and Daniela Schuster from University of Innsbruck. I would like to mention the funding, in particular by the German Research Council and the European Social Funds. And of course, I would like to thank you for your kind attention. Thank you very much.